Vijay Kumar. Dr. Vijay Kumar, you're muted. Dr. Vijay Kumar. Vinod.
Yes, sir.
You need to unmute Dr. Vijay Kumar.
हाँ सर, उनको कोच बनाया है बट वो रिस्पॉन्स नहीं दे रहे। वो उनको कोच बनाया सर।
Hello. Hello. Yeah, Dr. Vijay Kumar is still in the previous conference that has been delayed by 1 hour. So he'll be joining around 15 minutes later. His previous talk is still going on.
Dr. Vijay Kumar will be joining after 15 minutes?
Yes, 15 minutes.
Okay. Prathamesh, are you there?
Yes, sir. नहीं joined हुए sir अभी।
नहीं हुए। Dr. Kannan is also coming late.
Yes.
Okay. Okay, just a second.
Hi participants, डॉक्टर प्रधान ऑनलाइन है। मैं आपको सबको ये कर देता हूँ। आप खुद को अनम्यूट कर सकते हो। आपका कोई क्वेरी है या फिर कोई क्वेश्चंस है आप सर से पूछ सकते हो। जब तक अभी 15 मिनट्स के बाद में डॉक्टर प्रथमेश और डॉक्टर विजय कुमार ज्वाइन होंगे। तो जितने भी पार्टिसिपेंट्स है अभी ऑनलाइन, आपको अगर कोई क्वेरी है या आपको कोई क्वेश्चन करना है सर के साथ में तो आप कर सकते हो प्लीज।
Professor Vijay Kumar is delayed, so
Yes.
I think we should wait for him for about 10 to 15 minutes, and then Dr. Mohammed can start the presentation. In the meantime, if any of the postgraduates has anything to comment, what is it that you would, if you have any queries or comments, then please feel free to do that. You just unmute your mic and tell me.
Ronak?
Dr. Ronak?
Hello, good evening, sir.
Good evening, Ronak. All well with you?
Yes, sir.
Okay.
Yes, sir. How are you, sir?
I'm very well. I'm very well. Mohammed, you are going to present a case of thyroid?
Yes, sir.
Okay. I expect that the case will go on for about an hour.
Okay, sir.
After which Kanna will present a case of an interesting case of cancer of the larynx.
Okay, sir.
So otherwise, if we know that Dr. Vijay Kumar is going to be delayed much, then we can just start off the presentation. But in the meantime, if any of the students has any queries or any suggestions, then we can take them up. I see Dr. Ganesh Bangar and any of the students. Mohammed, tell us how many thyroids do you do in a week at the GCRI?
Thyroids are slightly sporadic, sir, because most of them are done by the ENT department in the civil hospital. We mostly get referred to thyroids for completion cases or for then lymph node dissection after a total thyroidectomy.
Mm.
So in the past around 3 to 4 a month, so not more.
Oh, that's fine. One of the things that I had planned for this evening was a talk by Dr. Krishna on the role of nuclear medicine in medullary cancer of the thyroid. Dr. Krishna, as you all know, is a very good speaker, very good teacher, and he has a lot of experience with nuclear medicine. And he has already shared with us his talk on differentiated thyroid cancers and nuclear medicine. But I wanted him today to do only on medullary cancer of the thyroid for half an hour, but unfortunately he's not able to come. But one of these days I will invite him again, because that's an important aspect that has not been covered.
हाँ सर सर अभी फ्री होने गए बट आप
Hello?
Hello.
Yes.
Good evening, sir.
Who is this?
Myself, Dr. Shivayak Mishra.
Yes.
I am from Delhi. Sir,
Yes.
I have a question regarding laryngeal CA.
Yes.
Sir, if we suspect on the indirect laryngoscopy that there is some subglottic spread of the disease, so sir, it is always necessary to do a suspensal laryngoscopy or direct laryngoscopy to evaluate the extent of disease, or CT larynx will be fine?
So generally, CT of the larynx will give you a good indication of what is the depth, the three-dimensional spread of the disease. But a direct laryngoscopy, 0-degree Hopkins telescopy, 30 or 70 degrees Hopkins telescopy will give you the surface extent of the disease, much better than a CT scan will do. So my preference is for doing a direct laryngoscopy, and direct laryngoscopy preferably with a Hopkins telescopy, a video laryngoscopy, 0-degree, and when necessary, particularly when the anterior commissure is to be assessed, then a 30-degree or a 70-degree Hopkins telescopy.
So is it possible with Hopkins and indirect laryngoscope to evaluate a subglottic region or post-cricoid region? Is it possible with that?
Yes, why not? Why will it not be possible to assess the subglottic extension of the disease? So this morning we had a very good case of, and I've told Dr. Manu to keep that recording because you don't see too many subglottic cancers. Primary subglottic cancer forms only a very small, very small percentage of laryngeal cancers. And today we had a primary subglottic cancer starting about 3 centimeters below the glottis. It was starting at the, you couldn't see the cricoid arch separately. We saw the vocal cords normal, and we go down 2.5 inch and a little more, nearly 3 centimeters, and you first see the stenotic lesion into the subglottis. It starts at the cricoid. It's really a less laryngeal and more tracheal tumor. And even biopsy of that was very difficult. So my guess is it may not come as a squamous cancer. It may come as an adenoid cystic carcinoma, or one of these ectopic salivary tumors. And the other, of course, is a cartilage tumor, a chondrosarcoma. But we've just done a biopsy today. So one of these days, Dr. Manu will show us the video laryngoscopy of that patient and also the suspension laryngoscopy. And then we can discuss how do we treat a subglottic cancer. What are the concerns that you have when you treat a subglottic cancer? The concerns about stromal recurrence and things like that. So,
Okay, sir. Thank you, sir.
okay. How many cases of cancer of the larynx do you do now, Mohammed?
Larynx, so most of them go for CT-RT. Salvage is also around, or upfront also around 2 to 3 a month in one unit. So both units combine around 5 to 6 on a higher side. Sometimes there's a month where we may not operate on a larynx. We don't have a facility for microlaryngeal surgery or otherwise. So T1, T2, T3 all go for CT-RT, and only T4A or then salvage surgery, so we tend to operate. So predominantly total laryngectomy is only so.
Predominantly, it is the oral cancer that you treat at GCRI in the head and neck service.
Yes,
Oral cancer.
in the surgical department, oral cancer, yes.
Yeah.
Oral and maxillary also to an extent, so we get a lot of patients.
Okay. Okay. Okay, I think if there are no other comments or questions from any of the participants, then I will request Mohammed to please start off the presentation. Then
Yes.
whenever Dr. Vijay Kumar comes in, you can recap it for him.
Okay.
Yeah.
Okay. Should I start, sir?
Yeah. Yeah. Please start.
Mrs. B, a 60-year-old lady, teacher by occupation, resident of Bapu Nagar, Ahmedabad. She came with the chief complaints of a swelling in the front of the neck, extending to the right-hand side since the past 2 years. The swelling was insidious in onset around 1 by 1 centimeter as per her description, which gradually increased in size to around 5 by 3 centimeters over the past 2 years. There's no history of any fever or pain associated with the swelling. She has no history of any cough. She has no history of any swelling anywhere else in the body, and no history of any voice change, difficulty in swallowing, or any dyspnea. There's no history of any irradiation in the neck in childhood. There's no history of any similar swelling in the family. She has no history of any cancer in the past. No history of insomnia, tremors, increase in appetite with weight loss or palpitations, or correspondingly lethargy, constipation, decrease in appetite with weight gain, and no history of any weight loss or any bone pains. She has no history of any treatment taken for the swelling. and no significant past history. Her sleep, bowel, bladder, and appetite all are unaltered since the past 2 years. She consumes a mixed diet and she has no addictions. Family history also is not significant, and she attained menopause at the age of 50 years. Should I proceed with examinations now?
Just summarize the history.
History is a 60-year-old lady, teacher by occupation, presenting
2 year history.
2-year history, sir.
Gradually increasing.
Gradually increasing in size, swelling in the front of the neck, extending to the right hand side, and no other complaints.
Yeah. Then all the other symptoms that you give of all the negative histories, you group them into histories where one needs to assess whether there are any pressure symptoms.
Yes, sir.
History where one needs to assess the toxicity, or history where one needs to assess or predict the malignancy. These three, you group them separately, then the mind remains focused.
Okay, sir.
So all the general things of a fever and all those things can come separately, but specifically for the thyroid, when you're doing, try and group your positive and negative history on these three main things, where it may be causing pressure, where it may be causing toxicity, and where there may be a possibility of malignancy. So if you do it that way, then the examiner's focus also remains, and he sees that you're focused on to arriving at a diagnosis. You get me, Mohammed?
Yes.
Okay. So swelling anywhere else in the body and all those things, you focus on to thyroid, and then you give all the other things, that is okay. All right?
Yes.
Okay, you can come on to the, have you made any judgment on based on the history, whether what you're dealing with?
Most likely, sir, thyroid swelling based on the location and given the fact that
Yes.
most likely a thyroid swelling given the location and given the fact that she has all the other causative etiologies, doesn't have any symptoms, negative etiology, negative history for the etiology, and causative history for the swelling in the thyroid unknown, so most likely a benign or can be a malignant cause. Cannot comment just now, just based on the history. More likely a benign because she doesn't have any positive history or causative history for malignancy, as in no familiar history or no history of any irradiation as such. Malignancy can be concurred based on the age group, sir, given that her age is 60.
Okay. Is it more likely malignancy more likely at age 60, or is
No, so that's just younger age groups and elderly age groups. That's not a very specific feature. It's more likely a benign cause just based on the history, sir.
okay? Let's go to the examination.
Yes. On examination, the patient was conscious, cooperative, well oriented to time, place, and person. Performance status was ECOG 0. Vitals were normal, and she had no evidence of any phallic cyanosis, clubbing, or generalized lymphadenopathy. Lymph nodes of the neck I would like to address in local examination, sir. And there was no tenderness in the spine, and skull was also normal. This is a clinical photo of the lesion, sir, where she has around a 6 by 4 centimeter oval lesion in the front of the neck, extending to the right hand side. The lesion arises around 1 centimeter above the sternal notch and extends around to the a centimeter or so below the thyroid notch. It slightly crosses the midline, and the lateral aspect is extending under the sternocleidomastoid. The skin overlying the surface is smooth, and there are no scars or sinuses seen, and there are no other swellings visible in the neck. And on asking her to swallow, the swelling moved upwards with deglutition, and the lower border of the swelling was also well seen when she swallowed, and there was no movement of the swelling, further movement of the swelling on protrusion of the tongue. And on palpation, sir, there was no local rise of any temperature.
Any indication of a tracheal shift on visual?
No, sir. The trachea was also normal. Sir.
No shift?
No, sir.
Because in this X-ray, it looks like it is shifted.
Yes, sir.
Okay. Then palpation?
On palpation, there was no local rise of any temperature or tenderness, and inspectory findings were confirmed. Around 6 by 4 centimeter oval swelling, firm in consistency, smooth surface, and well-defined superior, inferior, and medial margin. And lateral margin could not be well felt because the swelling was moving underneath the sternocleidomastoid. Again, the swelling moved with deglutition and did not move with protrusion of the tongue, and the lower border of the swelling was felt. There was no other swelling felt in the neck. There were no lymph nodes palpable on either side of the neck. Trachea was central in position, and both the carotid pulses were felt, and they were not displaced. And after on systemic examinations, prior to that, there were no signs of thyroid toxicosis.
They are in examination. Good evening. This is Dr. Vijay Kumar. I'm interrupting.
Good evening, sir.
Thank you
I
very
just
much.
joined. Sorry for the delay. I was in another webinar. It went on a little longer. Thank you. Please continue.
Thank you, Dr. Vijay Kumar. Thank you for joining us. Dr. Mohammed is from GCRI,
Yes, sir.
and he is presenting a case of goiter. And he has just finished the history. Mohammed, will you please recap it for Professor Vijay Kumar? Just
Yes, sir.
recap the history and,
Yes.
and the findings.
Yes. Good evening, sir. So this is a 60-year-old female presenting with a swelling in the front of the neck extending to the right-hand side. Since the past 2 years, the swelling was initially small in size and insidious in onset, and it gradually progressed to the current size. There's no other positive history, sir. And on examination, sir, this is a clinical photograph of the lesion, where it is around a 6 by 4 centimeter oval lesion in the front of the neck, rising around a centimeter above the sternal notch, and extending around a centimeter below the thyroid notch, slightly crossing the midline, and laterally going under the right sternocleidomastoid. And the swelling moves with deglutition and not with protrusion of the tongue. And on palpation, sir, the swelling was firm in consistency and a smooth surface and well-defined central, superior, and inferior margin. And there was no cervical lymphadenopathy, sir. And both the carotid pulses were well felt in its normal position, sir. And on performing an indirect laryngoscopic examination, both the vocal cords were bilaterally mobile, sir. And there were no signs of thyrotoxicosis either.
Yeah, what are you thinking now? You said 3 important points, that is moving up with deglutition, and you spoke about the surface, and you spoke about the consistency. Will consistency help you in any way in thyroid? A general question.
Yes.
Will consistency help in thyroid?
Commonly no, sir, unless it is really a stony, hard swelling in which and history suggests about very rapid growth, then I would think of highly aggressive, poorly differentiated tumor. Otherwise,
I am coming to a different question altogether. What is thyroid paradoxus? What is thyroid paradoxus? You heard me?
Yes, sir. I'm sorry.
Thyroid paradoxus, I asked.
Yes, sir. I'm unaware.
Okay. Thyroid, you know what is paradoxity, right?
Yes, sir.
What looks is not the same. Okay,
Yes.
that is what is called as paradoxity. Thyroid paradox is when it is smooth and firm in consistency, we tend to say it is a solid mass, but in thyroid, many times it's a tense cyst. And that is why I asked whether consistency will really help in every time. So you'll have to take both into account. One, the surface, if it is very smooth and it is firm, you must think in terms of cyst as well. That is what thyroid paradox is all about. On the other hand, if the surface is irregular and it is hard in consistency, you will have to really think in terms of malignancy. So, if it is the way this patient is photograph is placed, it looks for me, because I have not examined, that it is also it's a as though it is a smooth surface swelling. If it is a smooth surface swelling, you will be easily be carried away by the consistency. Should be very careful in telling what is the consistency, and that consistency should not help you in making a diagnosis later. That is why consistency we are talking. The anatomical tip you must know, in general rules we have to know. Number one, the plane of the swelling determines the anatomy of the swelling. The consistency of the swelling will tell you the pathology of the swelling. This is a general thumb rule. That is why I spoke so much on thyroid paradoxes, because clinical examination will mislead you if you do not know this, and we may take it to the other side when we are talking about the diagnosis. Please carry on.
Carry on, Mohammed. What is your diagnosis now? Already summarize it.
Summarize, so it's a 60-year-old euthyroid female, clinically, with a 6 by 4 centimeter painless firm nodule in the right lobe of the thyroid since the past 2 years, without any regional lymphadenopathy and without any compressive signs. Most likely a benign lesion of the thyroid.
Benign necessarily means what?
A benign site, more likely a follicular, either a follicular adenoma or cyst, as you mentioned, sir.
Pardon me?
A cyst, sir, a tense cyst, as you mentioned, sir. Slowly going. More likely a follicular adenoma.
This particular case with a euthyroid status of about 4 centimeters, confined only to the one lobe, because we are not having the benefit of we ourselves examining. We'll have to go by what you said. If you are telling that is the only nodule, there is no other nodule either in the same lobe or other lobe, then we'll have to be talking about as a solitary nodule of the thyroid.
Yes.
In the solitary nodule of thyroid, where there is easily moving, as you said, the firm but smooth surface, two things will come into your diagnosis clinically. It could be a tense cyst on one side, which is much more common. Even in colloid gutter, we can get a colloid cyst, right?
Yes.
On the other hand, it could be a neoplasm. Because it is mobile and there are no other signs and symptoms suggesting malignancy, probably it is a benign swelling, you will tell, as you said. But is there any other way clinically you think it could be malignant by any chance clinically? There are no lymph nodes, you have said, correct?
No, sir. Yes.
And it is mobile. It has got any compressive symptoms or showing any signs of compression. So naturally, you will think probably it is benign. No doubt. But is there any other way? I am asking. Because in this case, I don't see any other physical finding suggesting that it is a malignant. But for a leading question from you, what are all the things will suggest to you in this same presentation, same physical findings by history, if anything else will suggest you there is a malignancy or malignant change is occurring?
Sudden rapid growth, if there was in the history, sir.
Rapid growth means what?
In this case, sir, she gave a history of gradual progressive growth, but if the patient had the lesions, as she mentioned, since around 2 years, and in the past few months, it has suddenly increased in size, that would point. In this case, so based on the history and examination, I'm not really suspecting malignancy.
Correct. Because it's a long case, my discussion asked before we take you, what will you do in this case? We'll obviously ask next. But before that, in a thyroid swelling, will by any chance age help you to make a diagnosis of malignancy or otherwise?
Not less younger age and elderly age groups are more likely to have malignant lesions if you have a swelling of the thyroid.
Pardon me?
Younger and elderly, sir, more than 55 and less than.
What I am trying to make a case is age cannot suggest whether it is benign or malignant. Even in a childhood, you can get malignancy.
Yes.
On the other hand, as you said, advanced age also you can get. Even in young adult, you can get. An adult, only the types may change, subtypes may vary, but age will not probably help you in making a clinical diagnosis of malignancy. That is the point I am stressing. Most of the time, we'll take age into account. For example, if you take particular age, we'll say this is old age, and hence I'll probably think in terms of malignancy, you may say in another organ. Whereas in this organ, age is no exception to get malignancy. That is the point I am stressing. Agreed?
Yes.
Right. Then what else you will take into consideration?
Based on history only, sir.
Yes.
Whether she has any previous any family history of thyroid cancer or any other previous malignancy, breast or colon cancer. She has history of the same, sir. Either a familial history or a familial syndrome may lead to a risk of thyroid cancer. I may consider thyroid cancer more likely in that case.
You are talking about MEN, correct?
MEN, sir, for medullary, or also FAP or Cowden syndrome for a differentiated thyroid carcinoma also, sir.
Right. How do you go about now?
My first investigation, sir, would be that I would ask for a thyroid function test, and specifically, I would like to see the TSH value, sir.
Pardon me?
TSH, thyroid T3, TSH values of patient.
Can you tell me why?
To see if the patient is, as she is clinically, to confirm that she is euthyroid, and based on the TSH value, I will decide whether to proceed further with a sonography or then to proceed with a radionuclides cancer.
In this large lesion like this, kindly tell me, if TSH is low, what will you do? If TSH is high, what are you going to do?
If TSH is low, that means that the I would also like to see the T3 and T4 value. And if the patient is hyperthyroid, then I would proceed with a technetium 99 scan to see if it is a solitary toxic nodule. And if it is normal or TSH is high, then I would proceed with the sonography of the neck, sir, to see the characteristic of the lesions.
What are you averse with by putting a needle on this case?
Pardon, sir?
What is holding you back from putting a needle in this case?
Would you like to do an
sir.
aspiration, Mohammed? That's what
Yes,
sir is
sir.
asking.
I would first like to characterize the lesion, sir, prior to doing an aspiration, so that I can find out the exact areas from which I would do
What investigation will help you characterize it?
a sonography, sir.
That is what I am trying to tell. You have done a TSH, then the next investigation probably will be doing a ultrasound.
Yes, sir.
Ultrasound is going to suggest whether it is a cyst or a solid or mixed or solid alone, because that is one of the diagnoses which we are maintaining. It could be still a cyst. So
Yes.
if that is so, suppose if it is a cyst, ultrasound says, will you put a needle or not?
If it is a purely cystic nodule, and the patient does not have any compressive symptoms, then there is no need to confirm the cytology, sir. I can give her the option of creation of the cyst if she desires that, or else we can just keep the patient on follow-up, sir.
Yeah, proceed. In this case, what will you do now? Next, you will do now what?
I will do a sonography, sir.
Yes.
And should I show you the sonography reports, or
Yes.
the sonography showed around a 6 by 3.5 by 1 centimeter hypoechoic solid lesion with taller than wider appearance involving the right lobe of the thyroid with ill-defined margins and a cystic component of 7 by 4 millimeters. It did not show any internal echogenic foci or calcification, and it invaded the overlying thyroid capsule, and there were signs of internal vascularity on Doppler. Thyroid's grading of 4, and the remaining part of the right lobe and the left lobe and the isthmus of the thyroid all were normal, and there was no evidence of any cervical lymphadenopathy in the neck.
Can you tell me a little more on what is TYRAX?
TYRAX is a sonographic grading system for thyroid lesions from 1 to 5, where 1 being benign, 1 being normal, 2 being benign, 3 being probably benign, 4 being suspicious for malignancy, which is further divided into 4A, 4B, and 4C, and 5 being highly suspicious for malignancy. And based on the grading, there is a risk of malignancy attributed to the lesion, where TYRADS 2 has a less than 2% risk of malignancy. TYRADS 3 has a less than 5% risk of malignancy. 4A has a 5 to 10%, 4B has a 10 to 50%, and 4C has a 50 to 85% risk of malignancy, and 5 has a greater than 85% risk of malignancy. And further, 4A, B, C, and 5 are characterized based on the presence or absence of these 5 characteristics, which are a solid lesion, hypoechoic lesion, irregular margins, taller than wider, and microcalcifications.
Yeah, carry on. Next.
Next, based on this, I would like to proceed with a fine needle aspiration cytology. And the report of the same was showing moderately cellular smears with follicular cells arranged in seeds, macrofollicles and microfollicular pattern with mild to moderate degree of anisocytosis and nuclear crowding evident. The lesion was Bethesda 4 categories, follicular neoplasm.
Before you proceed, what is FNAC, fine needle non-aspiration cytology?
Fine needle non-aspiration cytology is where normally when performing a fine needle aspiration, you have a negative pressure given to the syringe and to introduce it into the lesion. When you're non-aspirating, you just introduce the needle into the lesion and move it up and down, and whatever tissue material comes in by that movement, that is taken up for the cytology smears.
Why at all it is described?
Because in lesions such as the thyroid with high vascularity, there is a chance where while aspirating, you may predominantly have an aspiration of blood. So in highly vascular lesions, just by movement of the needle, enough tissue can be taken up for the cytology.
What if some blood comes?
Uh,
How is it going to matter if the blood comes? Why we are worried about blood coming? After all, not even 1 ml blood will come, if at all.
Yes.
Why you are worried about blood? Is it because of the blood loss or something else? Why you are worried about?
I'm unaware for the exact reason.
No, I will ask the other way around. Why you don't want the blood to be mixed in the? What is the problem when it gets mixed in your aspiration?
For reporting of the lesions, the exact reason I'm unaware. Sir.
It will obscure what? No, you know the answer.
Cells, the clumps of cells which need to be visualized. Sir.
If it will obscure what? Blood once comes in, what will it obscure? The thyroid cells can be seen, whether with or without blood. It will obscure some other diagnosis. If I have to give me the
medullary parafolliculars.
No. Like lymphoma, etc. When it comes, when the lymphocytes in the blood or this, we will not know, then it will mix up.
Okay.
And as you said rightly, that it's highly vascular most of the time. So unnecessarily you will aspirate, blood we don't want. But more importantly, it will obscure in the cytological diagnosis of other lesions. In any case, we'll see the thyroid cells. If it is coming, you will see the thyroid cells. Okay, fine. That is for the knowledge. Coming to Bethesda category. What is Bethesda category of FNAC?
Bethesda category of FNAC has a grading from Bethesda 1 to Bethesda 6, where Bethesda 1 is a non-satisfactory smear. Bethesda 2 is a benign lesion. 3 is atypicia of unknown significance or follicular lesion of undetermined significance. Bethesda 4, as in this case, is a follicular neoplasm or suspicious for follicular neoplasm. Bethesda 5 is suspicious for malignancy. And Bethesda 6 is a proven malignancy. And based on the Bethesda category of grading, sir, there is a risk of malignancy attributed to the lesion.
Wait for a moment. Here it is Bethesda 4 and they are calling it as follicular neoplasm.
Yes.
You said what is 5?
5 is suspicious for malignancy, atypical, suspicious for papillary malignancy.
Papillary. Can they make out on FNAC carcinoma and follicular and adenoma? They can differentiate on FNAC?
No, sir.
Why?
Because for differentiating carcinoma from adenoma, they need to see capsular or vascular invasion, sir, which is not visible on a cytology smear.
Right. Carry on. Next. What will you do?
This is Bethesda 4 lesions, sir, with TIRADS 4C grading. In this patient, after this, there are two options we can proceed by, sir. One would be diagnostic hemithyroidectomy, and the the second option would be a total thyroidectomy upfront. Both,
Why total thyroidectomy for a benign lesion?
because it is a Bethesda 4 category, but
Right.
also it has high suspicious sonographic features for malignancy.
You have said Bethesda 4 is not suspicious of malignancy. You said 5 is malignancy. 6 is the confirmed of malignancy.
Yes.
Suspicious of malignancy, confirmed. Here is a place where you are telling Bethesda 4. And number 2, more importantly, they have given it as follicular neoplasm. We have already discussed that they cannot proceed to give you any further diagnosis on this in the form of cancer or otherwise. So you will have to call it as, it could be adenoma, it could be malignant.
Yes.
When this is the situation when we are in and we want to do surgery, okay, fine. Then why are you giving the second option of doing straightforward total thyroidectomy based on this diagnosis?
Because if there is a possibility given with the Bethesda 4 and the sonographic features that it may in final histopathology be a follicular carcinoma. And in such instances, because the size of the lesion is already more than 4 centimeters, she would require a completion thyroidectomy on if it was a carcinoma. So both options can be given to the patient, sir, and with the corresponding knowledge that she may require completion surgery if there is a requirement. So otherwise, pros and cons of both kinds. The first option would be a hemithyroidectomy.
Yeah, conventionally speaking, in this case with the follicular neoplasm, the first option only would be followed, correct?
Yes.
They will do a hemithyroidectomy, wait for the report, then proceed next, correct?
Yes.
Then why, with what idea you are talking about total thyroidectomy? Can you support your
Also, the
answer?
88
1 minute. Your can you support your second option with any standard protocols? Second option.
The ATA guidelines, the first option they give as a hemithyroid, a diagnostic lobectomy or hemithyroidectomy. And the second recommendation is that in patients in whom a diagnosis of malignancy on post-operative pathology would have recommended a total thyroidectomy in the first place. In those patients, after counseling with the patient, and if the patient has either history of family history or history of radiation or more than 4 centimeters in size, a second option of a total upfront thyroidectomy can be considered. So that is.
What is hemithyroidectomy?
Hemithyroidectomy is the removal of the one lobe along with the isthmus.
Can you explain to me why they have to remove the isthmus when the problem is on one lobe?
Not exactly sure.
Yeah. The idea of removing the isthmus along with the ipsilateral lobe has got 2 reasons. Number 1, if you leave behind the isthmus, it may get hypertrophied and it is in the midline, may cause a cosmetic problem. This is number 1.
Okay.
Number 2, just imagine this turns out to be a follicular adenoma. The higher incidence of adenoma occurs is in the isthmo-lobar junction. And so to overcome that problem, the isthmus along with the contralateral isthmo-lobar junction also will be removed. That forms the hemithyroidectomy, and that is the reason why we add the isthmus along with the lobe in question. Otherwise, lobe alone could be removed, they will say, number 1. Number 2, the terminologies. What when we say lobectomy is what American authors are talking about, and the European authors talking about hemithyroidectomy actually means the same, meaning the minimum biopsy procedure in a thyroid lesion is hemithyroidectomy. That is the concerned lobe with the isthmus along with the contralateral isthmo-lobar junction should come out. right? This is the answer for why you want to do a hemithyroidectomy in the first place. All right.
Yes.
Anyway, another leading question. Because you want to do as a second option thyroidectomy, total thyroidectomy, if it turns out to be malignant, you are worried about malignancy because in this case, only one criteria of what three criteria you told, that is 4 centimeter and above. There is no family history in this case.
No,
There is no history of radiation.
No.
So in that case, if you are so very worried, what prevents you from doing a needle biopsy? In thyroid, why you cannot or should not do needle biopsies? Formal core needle biopsy, I'm asking. Would you do? You didn't tell me. I'm asking a leading question.
Yes.
Why you cannot do a needle biopsy? When you can do FNAC, straight away you are going to hemithyroidectomy or otherwise. But this is a leading question, of course. You didn't tell. I'm asking why you should not do.
It would cause capsular abscess and bleeding. I'm not exactly sure. I don't remember off the top of my head.
But basically you don't do. Is it not so?
Yes.
Whereas just imagine it is a breast lump. What you would have done? An
Yes.
FNAC, if it is not contributing, you would have done a needle biopsy, correct?
Yes.
Then why we cannot apply the same rule here? There must be some reason, right?
Yes.
Yeah. Can you tell me the reasons?
Capsular rupture may occur, sir, during the true cut biopsy. Secondly, being a very vascular organ, again, risk of bleeding. Maybe that's all.
These are all standard questions, 1, 2, 3.
Okay.
They are worried about capsular. The third or second would be tract recurrence. The third most important one they avoid is not only vessel, but the nerves.
Yes.
You can easily injure the nerve. Here it is too big. But why, conventionally speaking, we don't permit formal core needle biopsy? The reasons are this. On the reverse, when will you do a core needle biopsy?
When
You should not do as a rule. I agree. I'm not telling what you are telling is wrong. I'm agreeing that yes, you should not do. But as an exception, when will you do?
Two conditions are there, so which I can think of where we would do. One is where you have when you're suspecting a B-cell lymphoma, and secondly, when you have a repeated indeterminate diagnosis, and you are still in doubt if and molecular testing has also not helped you for what the diagnosis is in those two conditions, but primarily when you're suspecting a B-cell lymphoma.
And also when it is a fixed swelling. When there is a fixed one, we are not able to, we know that hemithyroidectomy or surgery will be incomplete. You think that the alternate treatment like radiotherapy or can come in. For example, anaplastic carcinoma, you may think of a needle biopsy. Otherwise, what you said is correct. As a rule, we don't do needle biopsies. Okay.
Yes.
Can you tell me some of the other organs? Being long case, I have to ask you this. Where you avoid putting needle today? Other organs where you are said not to put a needle.
So specifically needle or so true cut biopsy?
Both you can tell now that you have said it.
You will not proceed for a biopsy at all for a liver lesion which is operable, a renal cell carcinoma lesion which is operable, and a pancreatic lesion where the radiological features will and tumor markers will guide you to the diagnosis. And
if you say this way, you will miss it. You come from top down. I'll give a clue. From head and neck area, is start.
Carotid, you will not proceed
Yes.
with biopsy.
Then come down.
Thyroid, as in this case.
Yes, come down to abdomen. Before going to retroperitoneum, abdominal organs.
Yes.
Anything?
Liver, pancreas, and kidneys.
Liver, pancreas, kidney. Coming down.
Ovaries.
In the liver area.
Bile duct, gallbladder. Sir.
Not bile duct, gallbladder operable cancers you will
Yes,
not put.
not. Yes.
Then coming down.
Uh, ovarian malignancy when you're suspecting.
Yes, ovarian. Then when you say ovarian, what else?
Uterine also, sir. Not uterine, sir.
If you say ovary, you have to think of testis. That's simple as
Yes,
that.
sir. Okay, sir. Yes,
Thank you. You proceed. Then, in this case, coming back to this case, what will you do?
Proceed with the right hemithyroidectomy, sir.
Okay. Now that when you do a hemithyroidectomy, there is one way is wait for the final histopathology report, fine. But still you are worried, it could be malignant. What is the role of per-op consultation, pathology consultation?
Frozen section for follicular neo lesions, it is not recommended by the ATSO, as it is not able to distinguish accurately between capsular and vascular invasion. So you should wait for the final histopathology.
In other words, frozen section in other places may help. Here, it will not help. It will be many times. It is they are going to say wait for the paraffin section. Fine. So we don't recommend doing it as a routine. All right. Fine. Next, what else? Suppose histopathology report comes as malignancy after a week.
Yes.
Follicular carcinoma. So what do you do?
I would, in the histopathology report, I would check for the vascular invasion of the tumor, sir, if it is more than 4 or less than 4 vessels are involved. And I would also check for the size of the lesion. If it is less than 4 centimeter, there is no vascular invasion. And then I can consider observation for the patient. But if there is the lesion is more than 4 centimeters, or there is any more than 4 vessels are involved, then I would proceed with a completion thyroidectomy.
When will you go?
Pardon, sir?
The report has come to you after a week. When will you plan to go back if you decide to do a completion thyroidectomy?
As soon as I receive the reports.
What are the problems of total thyroidectomy as against ME?
Total thyroidectomy, there is a chance for bilateral recurrent laryngeal nerve and permanent hypoparathyroidism, sir, compared to hemithyroidectomy.
You said you will go back and operate and completion thyroidectomy, you said, and now we have already got a diagnosis of malignancy in your hand.
And central compartment.
Yeah. What is the role of central compartment dissection?
Pre-operatively, if central compartment nodes are involved, then I will go for a formal central compartment nodal dissection. If there are no central compartment nodes involved on the sonography pre-operatively, or lateral compartmental nodes, then for differentiated thyroid carcinoma, I will just there's no need for any formal central compartmental neck. I will do an exploration of the central compartmental neck. So if I find any positive nodes, then I will proceed with a proper central compartmental neck dissection.
What are the current recommendations about the central compartment?
If there are no nodes, you can proceed, or there's no definitive consensus on the same, sir, where in a N0 neck.
Yes, if it is medullary?
If it is medullary, then I will proceed with at least an ipsilateral central compartmental neck dissection, sir.
Can you tell me the boundaries?
Boundaries would be the brachiocephalic artery below, sir, common carotid artery on either side. And if it's a unilateral, then the midline, and superiorly the hyoid ones.
What will be the, now you have done a total thyroidectomy. This is, it looks like a very basic question, but I still want to ask. So within 24 to 48 hours, the staff nurse calls you and you are making a diagnosis clinically that it is probably hypocalcemia. What will you do?
I will have
Tell
100.
me 1, 2, 3, 4. What will you do?
First is I would ask for immediate calcium gluconate to be administered.
I don't think I'll do that. I don't think I will do that. Before that, anything you'll do. Anyway, you are going to prick.
Serum.
You will draw the blood for calcium or not?
Yes, sir. Calcium and
You have to
BTS.
prove what you are telling.
Yes.
No. You have to draw the blood. Anyway, you have decided to prick, draw the blood,
Yes.
and send it for calcium,
Calcium
right?
and BTS. Yes.
And then start calcium. Now the question comes, how much calcium you will give, and how often you will give, and how long you will treat it with IV calcium.
If the patient is sudden symptoms, I will treat immediately with IV calcium. And once the clinical symptoms have subsided, then I will start him on a oral calcium tablet, sir. Twice a day.
No. I am asking a specific question to know whether you are dealing with that or not. You will draw blood for calcium, wait for the report, fine.
Yes.
But the patient has got a symptom suggesting or signs, you have made a clinical diagnosis. That means it is severe tetany, right?
Yes, sir.
And so you wanted to start also calcium. So tell me how much calcium, how will you give, what will you give, for how many hours? That's the point I'm asking. IV.
IV you can administer by the immediate dose by two routes. One is either 10 ml of calcium gluconate and 10 ml of saline over 20 minutes, slowly pushing it, or we administer in 100 ml saline drip over half an hour. And
How much? How much?
Yes, sir. 10 ml of calcium gluconate. Sir.
What is the body requirement of calcium per day? Basics.
Yes, I don't know off the top of my head.
Basics. I'm asking what is the calcium requirement per day, and by giving 1 ampule of calcium gluconate, how much you are giving, and what is the base calcium available in calcium gluconate?
I don't remember off the top of my head.
No, please go back.
Yes.
It is important that as a PG resident, you are going to see it. Calcium gluconate is 10%.
Yes.
So you are not going to get not even 1 gram of calcium by giving 1 ampule. By giving 10 ampules only, you will get 1 gram of calcium base.
Okay, sir.
You got what I'm telling?
Yes.
Kindly go back and see how to give in a severe tetany IV. You cannot give one push and keep quiet. One push is to immediately overcome, as you said, but you have to continue with the IV fluids and 24 hours drip, etc. There are several formula. The simplest formula to be followed would be 2 ampules of calcium, slow push, as you said, IV push, follow it up with the 2 ampules in normal saline and every 6th hourly. That means almost 10 ampules you would have given in 24 hours to see that at least 1 gram calcium is given, base is given to the patient. Because he has gone in for severe tetany, you will have to look at it that way. Then only you will go to, after seeing the serum calcium level, etc., you will start correcting the deficiency. Both IV and oral we can take. But when the patient has got severe symptoms, IV is the answer. Fine. Then what do you do next? After 2 days, patient was talking normally. After 48 hours, suddenly the patient is telling the voice is changed. What will you think of? Patient was talking properly post-operatively.
I will see the local sites if there is any tense swelling which is causing any.
Pardon me? Pardon me?
I will check the local sites for any compressive swelling in the neck as a post-op collection, which is causing compression. Uh, I will also do a indirect laryngoscope, a Hopkins examination to check for the vocal cord mobility, sir. And
When will you? No, I'm not able to hear well. There is some disturbance. When will you? Now this is over. When will you address the lateral neck?
okay, sorry. Lateral neck when there is gross nodal involvement, or
Pardon me. Pardon me.
if there is gross nodal involvement on the preoperative sonography, I will address the lateral neck. Or if my central compartment neck dissection is positive, then I will address the lateral neck on the same side.
Which side of the neck?
Same side of the lesion.
Ipsilateral neck. Okay. What is the type of surgery you will do if there is a N plus lateral neck? And what will you do if you are going to suggest probably there is disease, as you said now, because of the central compartment ipsilateral is positive, you go ahead. Actually, lateral neck is actually N0. Lateral neck is N0 in
Yes,
this
sir.
situation.
Yes,
In that condition, you will go and address electively.
yeah, I will electively address level 2, 3, and 4.
Pardon me?
Level 2, 3, and 4, sir, on the ipsilateral side.
2, 3, and 4. Why only 2, 3, 4? And why not 5?
Because it is clinically a N0 neck, sir. So the without 2 and 4 lymph node level involvement, it is unlikely that level 5 would be involved, and clinically.
Really? Yeah. Now tell me, what is the blood supply of thyroid?
Blood supply of thyroid is from the superior thyroid and inferior thyroid artery.
I am coming to inferior thyroid. Tell me, what is the inferior thyroid origin?
From the thyrocervical trunk, which is the branch of the subclavian artery.
So from where it comes?
It goes the inferior thyroid artery from the thyrocervical trunk. It loops behind the carotid, and inferomedially it moves towards the branches are given off to the lower pole of the thyroid.
What I am coming down, or you are not catching thyroid, the inferior thyroid.
Yes, I will address level 5 also.
You got what I am asking?
Yes, sir.
And why I am asking that question, right? Right. Now that N plus is there, you will do 2, 3, 4, 5. Why
Yes.
you are not addressing level 1 in thyroid? And what is, if it is positive, what is to be considered as?
The incidence of the drainage of the thyroid, so where normally is not to level 1 lymph nodes. So normally we do not address level 1 lymph nodes. And if it is positive, so then I'm not exactly sure if it would, as to what it would be considered, sir. Metastatic or regional spread, I'm not sure, sir.
It has to be treated as metastasis only. It is not considered as a regional node for thyroid.
Yes.
Whereas level, say, even anterior supremediastinum can be considered as regional node, but not level 1, right?
Yes.
Okay. Now, how do you go about treating this patient after total thyroidectomy? Surgically, patient has done well. What is the advice you will give, and what will you do next? It is a 4 centimeter lesion.
It is based on, sir, the histopathology, whether the patient falls into a low risk, intermediate risk, or a high risk criteria.
What makes you say, well, will say it is low risk when it is 4 centimeter? What are the other factors will say it is low risk?
Low risk would be less than 4 vessels are involved.
Here it is 4 centimeter, no?
Yes.
And above. So I'm asking, what are the other factors to make this as low risk? I asked.
No metastatic disease, sir.
Yes.
Serum thyroglobulin level is.
How do you know there is no metastatic disease?
Sorry. Okay. Yes. And so I will keep the patient on off thyroxine diet, and I will plan the patient for a diagnostic radioiodine scan.
Pardon me?
For a diagnostic radioiodine scan, I will keep the patient off thyroxine so that the serum TSH level can rise. And following that, once the serum
Raise what? Raise to what level?
more than 30 international units.
Okay.
And
What happens after 30 international units?
I will proceed with a
No. Why wait for 30 international units is my question.
for to stimulate for the uptakes of the if there is any disease present, the TSH helps in the uptake of the it needs to be stimulated so for the radioiodine to be taken up. So,
The distant spread, if it is there, occult spread, occult metastasis,
Yes.
they will not be functional till the TSH goes to an optimal level. That is the
Yes.
answer.
Yes.
So you wait for the TSH to go high, then they will start functioning if they are there. If you do earlier to that, even if they are there, the scan will be negative. That is the idea of waiting for 30 international units.
Yes.
What is the other way of doing it instead of waiting, making the patient go for hypothyroidism? Is there any other way?
You can use recombinant TSH, sir.
Yeah, correct.
So either of the two options you can proceed with. And,
Correct. Then what do you do?
Then I would do a diagnostic radioiodine scan.
What is diagnostic radioactive scan?
Diagnostic radioiodine scan is where only you use a dose of around 3 millicurie, and uptake if any occult mets or uptake in the thyroid bed or any regional lymphadenopathy is seen, and if that is based on that, so then I will further classify into low, intermediate, or high risk, and also plan further treatment using a therapeutic dose of radioiodine with
We'll
iodine.
come to therapeutic. We'll come to therapeutic dose. Don't worry. You
Yes.
have done a large dose scan to know what is happening to the rest of the body.
Yes.
Then now the activity is seen only in the thyroid bed area. Can it happen? You have anyway done a total thyroidectomy.
Yes.
Then can it happen?
Yes, sir, it can.
Why and how? How do you explain that?
You may be behind microscopic disease, especially
Disease?
not sir, it's a normal thyroid tissue. Most commonly near the ligament of at the ligament of Berry or at the where the recurrent laryngeal nerve is inserting, sir, in the cricothyroid membrane. So it is possible that normal thyroid tissue may be left behind at the.
By thyroid uptake, when will they call it as a well done total thyroidectomy?
There's
By
I don't get the
activity,
question,
they
sir.
tell it is a well done or not well done. Thyroidectomy, total thyroidectomy. You will claim I have removed both lobes and isthmus, and so it is total thyroidectomy. Correct?
Yes, sir.
When will the nuclear medicine person say, in radioactive iodine wise, it is a well done or not a well done one? Any criteria?
I'm not sure, sir, but if it's less than, I don't know.
Somebody is typing, so you will see that typing. Okay, fine. It is 3% and low is considered as well done. Okay. And if it is anything more than 3 to 6%, they will accept it, but okay, they will say. But anything more than 6%, they may not accept it as a well done one. All right.
Okay.
Fine. Now coming back to this case, you have done a total thyroidectomy and you have done a scan. And tell me, when will you do therapeutic dose? Thyroid ablation, radioactive iodine ablation.
Radioactive iodine ablation, so I will proceed if the patient falls under the intermediate or high risk category, which I was mentioning earlier, sir. you will go for thyroid ablation when you have any metastatic disease, sir, or the patient in the intermediate risk category is where there is uptake in the any uptake outside the thyroid bed, sir. Or when there are high risk features such as vascular invasion or poor histology such as columnar, hobnail or tall cell variants, or there is any microscopic, there is any gross thyroid tissue left behind. If there is any lymph nodes are positive on
In GCRI, what type of therapeutic dose is given? Low dose therapy or high dose therapy in GCRI?
100 high dose therapy, sir.
Yeah. High dose therapy, how it is different from low dose therapy, so-called domiciliary therapy?
Low dose therapy, sir, is 30 millicurie is given instead of 100 millicurie, and in that the side effects are lesser compared to when you give a high dose therapy, but the efficacy of the dose of the treatment is lesser compared to when you give a high dose therapy. So you may require a repeat treatment if the dose given is not effective.
After the large dose therapy, large dose scan and then radioactive iodine ablation is done, when will you start thyroxine? And how do you titrate thyroxine?
Based on after the yes, titrate thyroxine is based on the risk category, whether low, intermediate, or high risk category. So I would want to achieve a particular TSH level based on the category. For a low risk category, I would want to achieve a 0.5 to milli international units. For an intermediate risk, from 0.1 to 0.5, and for a low risk, for a high risk for TSH value, I would like to keep it in the range of less than 0.1. And for that, initially, I would start with a dose of 200 micrograms of thyroxine, and then as the patient achieves a normal range of TSH, for the titration of the dose up to 125 or 100 or 75 micrograms of thyroxine based on what range I want to keep my TSH in. But you normally start off with 150 to 200 and then titrate the dose of thyroxine downwards to achieve the recommended levels. And
Yeah, fine. This patient has done well. How often you will call this patient and do what?
I will call the patient 6 to 12 monthly, and if it is again, so based on the response, it can be classified into excellent response, biochemical response, structural response, or indeterminate. An excellent response, then I will call the patient every 6 to 12 months and do a unstimulated thyroglobulin level along with the antibodies, so anti-thyroglobulin antibodies, and I would the thyroglobulin level is normal, and also a clinical neck examination, so, and if the thyroglobulin level is normal, then again I would proceed for yearly follow-up, and follow-up would be have to be maintained lifelong.
And after 5 years of follow-up, the same patient comes to you routinely. You have done thyroglobulin, so now you do, and the thyroglobulin is raising.
Yes,
what will you do?
I will proceed for a diagnostic radioiodine scan.
Negative.
I will first confirm the thyroglobulin, the anti-thyroglobulin antibodies, and it's rising, so I'll proceed with a diagnostic radioiodine scan. So,
Negative. But thyroglobulin is raising.
then I will consider that the patient for a tennis syndrome, which is thyroglobulin elevated with a negative iodine scan, and I will proceed for other imaging modalities such as a PET scan.
Is
And,
there any other indication for PET CT in thyroid cancers apart from what you said now, which you said correctly? Is there any other indication for PET CT in well differentiated, say, thyroid? Answer is
no, sir.
no. Answer is no. This is the only indication for a PET CT. Otherwise, it is always radioactive iodine uptake studies or radioactive iodine scan only. Fine. From my side, fine, sir. Dr. Sultan Pradhan, sir.
I think extremely well examined, Dr. Vijay Kumar. And I would request Mohammed to
Yes.
please summarize the whole discussion today and then circulate it to all the participants. I think it's very, very useful, very simple and practical questions. Everyday problem is what Dr. Vijay Kumar has highlighted in his questions. Extremely well done. I want to make one comment, Mohammed. If you have a follicular neoplasm as your fine needle aspiration cytology, and you do a hemithyroidectomy, there is no harm in doing a frozen section. You may have a follicular variant of papillary cancer, which can be diagnosed. And occasionally, a smart pathologist will even will differentiate between a follicular adenoma and a follicular carcinoma if she notices the capsular invasion. So I think that if you have facilities for frozen section, it is worthwhile doing that on a follicular neoplasm when you do a hemithyroidectomy. Number two, I thought you mentioned that if I do an ultrasonography and if it is a complete cyst, then I will do nothing, I will just follow her up. Is that what you would do for a 6 by 4 centimeter, such a large nodule in a 60-year-old?
I would proceed with aspiration, sir. Complete aspiration of the cyst, and if it is recurs more than 3 times, then to proceed with a diagnostic lobectomy.
Proceed with a
diagnostic lobectomy, hemithyroidectomy.
Yeah, diagnostic therapeutic lobectomy. At age 60, you don't want her to be there with a 6 centimeter nodule in the thyroid. Even if she's not bothered about the cosmesis, you have to be bothered that in time to come, this is going to cause compression, or this may cause compression. And when her health is good, 6 by 4 centimeter nodule in the thyroid, you cannot be very academic and say, no, this is a benign thing and I will not touch it. You have to take it out even for its size. So I just thought I should mention this. But I would really suggest you summarize everything that we have discussed, and the way Professor Vijay Kumar has guided us, I think it will be very helpful to all the other students, and we will circulate it. Please do that for me.
Yes.
Okay, Mohammed? Kanno, are you there? Does any of the students have any questions? Then you can feel free to put up those questions for Professor Vijay Kumar. Kanno, are you there?
Yes, sir.
Okay. Would you like to present the case now, Kanno?
Yes, sir.
Kanno wants to present a case of an early glottic cancer, a T1 glottic cancer. And Dr. Vijay Kumar, I'd like you to even tackle him, because there's a lot that we can learn from you.
Thank you, sir. Thank you very much.
Yeah, I think the students need to have this kind of grounding.
So this is a case of a 68-year-old gentleman who had presented with hoarseness and in 2012 he had undergone a transoral laser resection for a left vocal cord lesion, sir. This was the operative notes mentioned that it was a verrucous lesion that was confined to the left vocal cord,
with the paraglottis being supple. So type 2 left vocal cord, left cordectomy was done. Exposure was good and resection was satisfactory. The histopathology revealed a carcinoma in situ with no stromal invasion. He then presented to us recently in the
One second. Can I interrupt?
Yes, yes.
Hello?
Yes, please do. Please do.
No, I don't know whether he's hearing me. Sir. Hello?
yes, sir.
You're able to hear me, Kumar?
Yes, sir.
You said carcinoma in situ, right?
Yes, sir.
Without stromal invasion, you said, can they both exist together? Stromal invasion as well as carcinoma in situ.
No, sir.
Then why that comment saying that there is no stromal invasion? When you say carcinoma in situ, we know that it has not crossed the basement membrane. Is it not so? Is it so? Correct as no?
Yes, sir.
Right. Please continue.
The gentleman was then on follow-up and he had recently developed hoarseness. This is his findings from the Hopkins examination, sir. There was a lesion seen over the left vocal cord reaching the anterior commissure. Both vocal cords were freely mobile, sir. He was then planned for a microlaryngoscopy, sir. These are his findings from the microlaryngoscopy. This shows a lesion over the left vocal cord, mid and anterior part of the left vocal cord, reaching the anterior commissure, sir. A laser resection was then done for this lesion, sir. It was an indurated lesion over the left vocal cord, reaching the anterior commissure but not crossing over to the other cord. A transoral resection was done, and resection was complete with with satisfactory exposure, sir.
What is the point you are driving at?
So with this case, we see that for an early glottic cancer, a T1 glottic cancer, transoral laser resection is a good choice for treatment of a T1 mid-cord early glottic cancer, sir. The advantages being that it is a one-stage, it's a single-day procedure with good post-op quality of voice and with results equivalent to radiation, and post this patient can also any recurrence can be treated with probably with laser again or radiation, which both cases we can preserve the larynx. While if we treat a patient with radiation, it may be difficult to preserve the larynx in the case of a recurrence.
If you had a report of a carcinoma in situ, would you consider radiation therapy?
No, sir. In an in situ carcinoma, no radiation.
You would not. How would you treat it?
Sir, with resection with the laser and then just maintain close follow-up.
And if you didn't have the laser?
Sir, cold steel excision can be done. Sir.
Sorry?
Cold steel instruments can be.
Yeah, cord stripping. Any other case you have, or?
Yes, sir. This is the case of a 58-year-old gentleman, sir. He has previously undergone laser resection, sir, several times. First was in 2016 when he had a indurated lesion on the right mid cord, not extending to the anterior commissure with a supple paraglottis. So transoral laser resection was done. It showed a moderately differentiated squamous cell carcinoma with margins and base being clear. He then developed a recurrent lesion over the right vocal cord, which was again excised with the laser in 2017. Again, the margins were found to be clear. In 2020, he then developed a lesion at the anterior aspect of the right vocal cord, which was again resected by the laser. This showed a carcinoma in situ. He then presented with hoarseness of voice, recent onset hoarseness. This is his Hopkins examination, which shows lesions were bilateral anterior vocal cord and anterior commissure, but both cords being freely mobile.
And each time it has been an invasive cancer or an in situ?
So twice it was an invasive cancer, and the third time it was an in situ carcinoma.
What is the other advice that you give to the in situ cancer? You said you will not radiate. What else will you tell them?
Sir, if to stop smoking, sir, if they're smoking, they should stop smoking.
And constant follow-up.
Yes. This is his 30-degree Hopkins microlaryngoscopic examination, showing lesion over bilateral anterior vocal cord and anterior commissure, and some leukoplakia is seen in the subglottis.
Dr. Vijay Kumar, you can take over and tackle him.
No, thank you, sir. This is being a early disease. What is the role of radiotherapy here if it is invasive? Same lesion, but invasive.
Sir, for depending on the when I suspend the patient and do a microlaryngoscopy, I would like to assess the extent of anterior commissure involvement. Usually in cases where the lesion is extending onto the anterior commissure, post laser resection voice quality is not good, sir. There is a tendency for a web formation as well post resection, and there is the results may be better with radiation therapy if we cannot get a margin at the anterior commissure. So one may even consider treating the patient with radiation therapy, sir. Bilateral vocal cord and anterior commissure.
What type of radiotherapy and what is the dose given?
Sir, definitive radiation is given, sir. Dose of 60 to 70 gray is given, sir, in 30 to 35 fractions.
In most of the radiotherapy planning, they will include the drainage area also. Whereas in a T1 commercial carcinoma, invasive, what will be your suggestion or their suggestion would be with respect to the drainage area?
Sir, a T1 glottic cancer, sir, I would only like the radiation field to be limited to the larynx, sir, and not because of...
Why?
Because the chance of nodal metastasis from a T1 glottic cancer is very low, so less than 5%. So I would not like the neck to be radiated, sir.
What type of radiation nowadays they are giving in your center? Type. You said the intent.
Yes,
intent was definitive radiotherapy or so-called primary radiotherapy, right? With an intent is cure, radical radiotherapy. Fine. But I am asking what type?
Sir, intensity modulated. I am artist.
External beam radiotherapy, that is intense modulated. What is intense modulated radiotherapy?
Sir, the patient is using a CT scan. The patient is planned and the dosage is varied so as to minimize the damage to the surrounding structure.
Now, how it is different from the conventional radiotherapy given by whichever machine it is, whether it's linear accelerator or cobalt, but how IMRT is different.
Sir, a higher dose is administered to the main tumor bed.
First of all, there is tumor. There is no tumor bed here. There is tumor. It's called as target volume, right? The target volume should be reach the maximum, but the immediately next to that normal place should not get that amount of radiotherapy. That is not possible earlier days. Now with IMRT, actually 3D CRT, that is three-dimensional CRT itself, it started coming. And later with IMRT, it has improved a lot. But the differential treatment, the size and the shape can be handled by IMRT effectively. How? Any idea? Don't tell me I'm not a radiotherapy PG, sir. I'm aware.
No, sir.
They are called as collimeters. With the collimeters, they can give differential size and shape, but at the same time, uniformity can be given, and thereby even different sizes and shapes can be effectively treated without affecting the normal tissues. The main issue of giving radiotherapy is normal tissue should not be getting that much radiotherapy. At the same time, the target volume, what we call, should get the optimal dosage. And particularly in this area, in the olden times, if you give it cobalt, the problem would be with respect to the spine, etc., etc. Here, those things will not come into the picture. And with the CT planning system, you will be able to give IMRT effectively and appropriate dose can be achieved. That is why today IMRT is the preferred one, as you said correctly, and also more effectively you can treat to that extent that you need not do surgery at all. Anyway, coming to the voice, what will be the voice now when compared to your laser excision vis-a-vis radiotherapy?
Sir, for early T1 glottic cancer, sir, voice qualities is comparable in both laser and radiotherapy, sir.
Radiotherapy, you think the voice quality will be as good as your surgery in a T1?
Yes, sir.
What are the sequelae of radiotherapy? Apart from voice change, which I am talking, any other sequelae, immediate effects as well as long-term effects?
Sir, mucositis.
Yes. No, immediate is mucositis, correct. It is called as radiation-induced mucositis. Then what else? Long term. Patient will come and tell you, I am not able to do this, I am not able to do that. What is that?
Sir, difficulty in swallowing, sir.
Due to?
Sir, in the immediate period, it is due to the mucositis.
Late period?
The fibrosis, sir.
No, somebody is telling fibrosis. Don't listen to all that. They are telling wrong. They are misleading you. Xerostomia.
Yes.
Xerostomia is the main issue which makes it dry and the patient will not be able to swallow because of the dryness. So you will be encouraging them to take sips of water every time when you are swallowing, right? That is the most difficult thing to treat because it can never reverse. Okay. Right. When will you offer this patient a laryngectomy at all? Now I am talking about a case where you are irradiated, he has done well and has come back to you and you are seeing a lesion. Recurrence is there, definite, but there is no other evidence of this anywhere else.
So in most cases who develop a recurrence post radiation, they would require a total laryngectomy, sir, and that is also the safest option. Partial laryngectomy is only feasible in certain situations if the initial lesion prior to radiation that should also be that should be well documented, and it should have also been amenable to the same voice conservation procedure then. And the tissue should also be supple. That is only when you can consider partial laryngectomy. Otherwise, most cases would end. The safest option would be a total laryngectomy. Sir.
I would still bat for total laryngectomy. I don't know what Dr. Sultan Pradhan is going to tell me. In fact, I still remember reading his book for my MCH. So he is sitting there, so I don't want to comment. It's a separate book or he has written on laryngectomy. I don't know how many of you still have that editions. I have that edition, the old one. But what I am trying to suggest here is post-RT failures are better treated with total laryngectomy instead of making any other attempt to conserve. Sir, your viewpoint, sir.
If you had a lesion that you have seen prior to the radiation therapy, and if that lesion was amenable to a voice conservation surgical procedure, but for some reason that procedure was not done and you was treated with radiation therapy. After radiation therapy, if that patient gets a recurrence, and if the lesion is still amenable to the same kind of voice conservation surgical procedure, and the rest of the larynx is normal, non-edematous, then there is every justification or I would say then there is no justification in doing a total laryngectomy. But if somebody else has assessed before, you have not seen that, now he comes with a lesion which looks like it is amenable to a partial laryngectomy. I think it is safer to follow what Dr. Vijay Kumar is saying, just do a total laryngectomy. We've all burnt our fingers, tempted at doing these partial laryngectomies or transforaminal laser resections in cases that you have not assessed before. But if you have assessed it before, and if it was a certain lesion that was amenable to, say, a hemilaryngectomy, a vertical partial laryngectomy, he comes back sometime after the radiation therapy, and the tissues are good, healthy. The arytenoid is not edematous, the cords are still mobile, it is the same kind of lesion, then I think there's every justification to give him a trial with the voice conservation surgical procedure. And we have many such cases. We have many cases where we have been able to do a voice conservation procedure and have done well. Of course, there have been cases where we burnt our fingers also. So you're right, safest thing, like Kannan Kumar has said, total laryngectomy in majority of cases.
Thank you, sir.
Thank you. Most grateful to you, Dr. Vijay Kumar. I'm so happy to see you after so many, many years.
Yes, sir. Thank you, sir. I'm also happy to see your face, though I have talked to you.
And you have examined the candidates so well, so very well, so very well. I think this is how an examiner should be. So very well you've examined them. Dr. Mohammed will summarize the whole thing and will send you a copy also. And I'll also request you to do more sessions with us.
Thank you, sir. It's an honor to be with you, sir. Definitely, yes. Thank you, sir.
It is our pleasure. Thank you very much. Thanks a lot.
Have a good night, sir. Thank you.
Good night. Good night. Thank you, Kannan. Thank you, Dr. Mohammed. Prathamesh was not able to join today, nor was Kannan able to join today. Kannan is operating. Prathamesh is also delayed today. But you were there. You made it up all.
Thank you, sir.
Thank
Good
you
night, sir.
very much.
Good night.
Good night. Good night.